Welcome to this edition of AFMC
I'll tell you how I got better. I'm
Glad to be here.
But a mission to
Delivery of
improve.
I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Ann Eads. She serves as the Program Director of the Geriatric Psychiatry Residency and Program Director for Interventional Psychiatry at UAMS. She is an Associate Clinical Professor in the UAMS Department of Psychiatry and is an expert in treating anxiety disorders, depression, non-Alzheimer's, dementia, and what she calls treatment-resistant depression. Dr. Eads, thank you so much for joining us.
You're welcome.
So let's talk about treatment-resistant depression. What does that mean?
So treatment-resistant depression is usually defined as a failure to respond to two or more antidepressants that have been tried for adequate length of time and at an adequate dose, maxing out the dose if possible, if not going to the dose that you cannot tolerate it because of side effects.
And is this something for adolescents, adults, children? What are you seeing?
I work with adults.
Adults. And what are the most, when you say treatment-resistant depression, most prevalent treatments for it that you're seeing after medications?
Well, usually when we start out treating a depression, we start out with therapy and medication management, but probably 10% or more of the population as a whole does not respond to our antidepressants. Does respond somewhat, but not fully, and are still struggling, are unable to tolerate our medications due to a variety of side effects. And then that's when we move more to interventional psychiatry, where we start looking at different ways to manage depression, and that would include stuff like ECT or electroconvulsive therapy, TMS or transcranial magnetic stimulation, and ketamine therapy.
And so you mentioned ketamine, and there's now a nasal spray under medical supervision that's a part of a treatment. Are you seeing ketamine become more popular in this type of treatment?
Yes. Ketamine started out in the mid-1990s when psychiatrists began to notice that what we call a subtherapeutic anesthetic dose was helpful for temporary relief of depression symptoms. And it actually was a study initiated at Yale began to publish reports on that. And that's when it started becoming popular as use of a drug that might be potentially useful for psychiatry. And so the initial foray into use was with the IV ketamine or the interventional ketamine, with treating about 6 treatments, 2 to 3 a week, and that was found to be helpful. And then over the time period, they began to look closer at the ketamine molecule, and they developed a nasal spray, which is called S-ketamine or Spravato. S-ketamine only contains one enantiomer, the S enantiomer, whereas IV ketamine contains both the R and the S enantiomer. The S enantiomer is thought to be a little bit more potent. And so Janssen, who produces the drug, developed it into a nasal form and submitted it for FDA approval. And it was released with an FDA approval under what's called a REMS program, which is a very structured program that has parameters around of its use.
So why would you recommend this? Is it when the other treatments are not an option?
It is one of the 3 main options we have for treatment-resistant depression. It has its own benefits. It doesn't involve the side effects that you might see with ECT, especially the rare risk of memory. It is an augmentation strategy, meaning it's given with another antidepressant to make that antidepressant work better, and you keep using it on a regular basis to maintain your stability. Whereas TMS is FDA approved for mild to moderate. Esketamine or nasal ketamine can be helpful for the more severe cases.
What is the success rate for that?
It is very individual dependent. About a third of people get really good benefits and are able to go down to almost no depression as long as they maintain a maintenance program. About a third show some significant improvements, and about a third do not show much improvement with the nasal ketamine.
So let's switch gears for just a second. And does a PCP have to refer for a patient to see you or to use your clinic?
Well, by definition, this is indicated for treatment-resistant depression, and so we feel like that that it really should involve a psychiatrist or a psychiatric provider. That they should have gone through. If a PCP has not been successful in managing and getting good control of the depression, then maybe moving to a specialist such as a psychiatrist that can review everything and maybe think of some different medication options that hasn't been tried that might be helpful before moving on to the more interventional techniques.
And are there inpatient and outpatient treatments through your clinic?
Right now, esketamine is an outpatient medication. We do offer IV ketamine inpatient or outpatient if for certain criterias, but IV ketamine is not FDA approved, even though there is extensive literature supporting its use. It is because it's not FDA approved, then it's out-of-pocket pay, whereas nasal ketamine is paid by insurance, by a variety of insurance policies.
So much of our audience is healthcare providers and community partners and those that want to learn more about your treatment and your work. What are some misconceptions and things that you think are evolved around these treatments that you want to clear up?
ECTs are most effective. We have the most literature for it, but it does have some risk, and the most concerning one would be the potential risk of some possible memory issues. TMS is helpful for our more milder depressive resistant people, and the ketamines can be helpful as far as taking a drug that they've had some response to, or helping to make that drug work better, so that you don't have to go through changing another drug and waiting through the time period that you would expect to see it work, or the side effects that you might be associated with moving to a different drug.
Okay. Well, Dr. Eads, thank you for chatting with us about this important work and what you're doing at UAMS. I appreciate your time.
You're welcome.
And that's it for AFMC TV. Have a great day, and thanks for watching.